let's go to the next speaker, who is Arseniy Yashkin, whose title, he's here at Duke in the Baru group, the minimum data set and Medicare linked data, design methods and applications. While we're setting it up, there was a question for the last speaker about references to, just a minute.
I'm going to find that
Reference,
one and reply to everybody so that everyone has a reference of that.
it was references for the last article.
Yes, I will do that. Thank you.
Yeah.
All right, so I hope everyone can hear me. So today I'm going to talk a little bit about the minimum data set, how it relates to Medicare linked data, and how useful it may or may not be to the study of Alzheimer's disease. We'll talk a little bit about design, a little bit about methods, and very little about application. It's sort of the redheaded stepchild of this presentation. We'll look at some. So just as a quick background, in the US, the Medicare social health insurance system pays for the healthcare of over 98% of the US population of adults age 65 plus. The 98% number is from 2010. I don't think it changed that much since then. So pretty much everyone. Health insurance are provided by one or two models, traditional fee-for-service model or the managed care model. The traditional fee-for-service model includes Medicare Part A, which is an entitlement covering inpatient, hospice, skilled nursing facility, and part of home health care. Medicare Part B requires payment of a monthly premium and covers physician practices, outpatient, a different part of home health care, right? So home health care is sort of split depending on what you're getting, as well as some types of durable medical equipment. And just to be aware, when you're dealing with durable medical equipment, read the rules, don't just look at the code. Because depending on the equipment, they have different rules of how often you're allowed to buy it. But it exists. And finally, we have Medicare Part D. It's available from 2006 and onwards. It requires parts A and B in order to qualify. And this will actually translate into some data artifacts, this requirement. We'll see it a little bit later on in the presentation, just something to keep in your mind. And this provides coverage for prescription drugs. In contrast, the managed care model, also known as Medicare Advantage and Medicare Part C, I think they renamed it from Part C, I think in 1998 they renamed it. But whatever they did to it, it's still the same thing, right? It's a private managed care version of Medicare and provides the equivalent of Parts A, B, and D to people that sign up to it. Now, the exact benefits vary by plan, and they may provide more care like dental or vision and other things that aren't available under the traditional model. Two things to know. First, you can't, for most Medicare Advantage plans, the CMS will not give you data, so they don't have it available. Where you need to go is you need to go to MarketScan or a different database of private insurance claims. These are available, but to the best of my knowledge, I don't think these are actually linkable to the same people under Medicare, because you can switch, you can go back and forth. So they're in a separate box, but you can get them if you want. However, the demographic and enrollment characteristics for all of the Medicare Advantage individuals are in the Medicare enrollment files. So if you're interested in studying mortality, that's not that big a limitation. I mean, if you're interested in studying certain diseases, you need to start worrying about the proportion of people in Medicare Advantage, so on and so forth. Now, within the age and time boundaries of the available data, Medicare claims allow us to identify a fairly wide range of health-related events by providing us information on diagnoses made, pretty much international classification of disease, 9th or 10th edition codes. And again, they don't necessarily translate one-to-one. right? You can find a mapping, but there's no guarantee that it's going to be 100% valid mapping. You may have data artifacts, and that's a good time to check any trend that you're trying to calculate. It also provides good information on the medical procedures performed through either current procedural terminology, healthcare common procedure coding system, or procedural international classification of disease codes. Funny thing is, current procedural terminology and healthcare common procedure coding system codes are in the exact same field. So if you're new to Medicare analysis and you're trying to find two different fields, you're not going to find them. They're in the exact same place. They're also 5-digit codes and they don't overlap with each other, so it's hard to make a mistake. Now, in addition, it provides a range of other useful healthcare related information, such as the type, dose, and days supply of prescribed drugs. This comes from Part D, the specialty of the treating physician and the setting of care. You can study ambulance services, anesthesia times, all sorts of useful things are available. It's nationally representative of the 65+ population, which is great for us in studying Alzheimer's. It covers 100% of the United States with zip code level geographic data for both beneficiaries and for providers, which again allows us to leverage different sources of data that can be aggregated at the zip code level. It's longitudinal in nature and data is available in a reasonably standardized form from as early as 1991, as late as 2008, and it gets updated fairly reasonably. So it is possible to get data from before 1991. It's probably, for most research applications, it's not a good idea because it doesn't look the same as the later files do. And it's so far away that a lot of the practice has changed. So you can look for it, but I don't think there's too much benefit to be had. Finally, depending on your release, there's a large sample size, which is sufficient for the study of relatively rare diseases, which Alzheimer's at the end of the day is. It's a relatively rare disease. Now, just as an example, it is quite possible to use just a 5% sample of Medicare to create reasonably accurate state-specific maps of prevalence, incidence, mortality, what have you. These are aggregated at the state level, but the same program can regenerate these maps at the county level or even the zip code level. The thing that you need to worry about is the less of a sample size you have, the more missing counties you're going to have in states with low population counts. But if you have a lot of money and you manage to convince CMS to give you the whole 100%, your maps are going to look pretty good. But even at this level of aggregation, you can see a lot of interesting things. So for white Americans, all the usual suspects show up, the South and the stroke belt, high prevalence levels. For African Americans, we even see something funny. That's Maryland. It does look like Maryland. There's a very unexpected hotspot right on here. And it's quite interesting to see why it could exist. Maybe there's nursing homes or some other local political reasons for there to be a large concentration of African Americans with Alzheimer's disease. Could also be a mistake, never know. Medicare, however, is a payer for medical services. It doesn't provide medical services itself. This, together with the administrative nature of the data, imposes certain limitations. Among them, it identifies the presence of a bill with a diagnosis, not the presence of a disease. This is especially important in the case of Alzheimer's disease, which is hard to diagnose. And if you claim that you used the code and you found Alzheimer's disease, you're going to get a lot of reviewers that aren't going to be very happy to read that. It only captures episodes of care eligible for Medicare reimbursement. Or in other words, if Medicare pays for it, you're going to see it. If you pay for something out of your pocket, there's no reason for it to show up. If you don't use your Medicare, even if you're old enough, you still have private insurance, it's not going to show up. If you have alternative sources like Medicaid, part of it is going to go to Medicaid. You're going to get a partial picture. So again, this is specific to the Medicare program, and it's important to recognize that. It is subject both to over and under coding of individual diseases, procedures, and conditions in response to local coding practices and financial considerations. For example, using Medicare data, it is possible on a consistent basis to identify that obesity is really good for your health. And why does that happen? Because obesity in a Medicare claim is usually coded prior to bariatric surgery. You need to justify getting paid for your bariatric surgery. And bariatric surgery is probably good for your health, especially if you were obese before, right? So the effect makes no sense whatsoever until you start looking at the nature of the data where you're trying to find the effect. So again, not designed for research, requires experience of the subject matter to avoid introducing bias. Mistaken or tentative diagnoses, they remain on record and are not corrected retroactively. Your doctor may tell you that, no, you don't have Alzheimer's disease, but the record doesn't care, it just stays on record. There's a possibility of multiple claims for the same service. This is especially clear in anesthesiology services, especially if you have an anesthesiologist and an assistant. They will bill separately for the same procedure, claiming the same time. And boy, can you double count those anesthesia minutes if you don't pay attention. There's changes in coding practice. It's an introduction of new and removal of old codes over time. Generally, trend analysis prior to doing anything else finds these. And again, we have the ICD-9 to ICD-10 switch. Now, such data by nature suffers from right censoring and left truncation. What does this mean? It means that we don't know about a person's health status until he gets in the system and starts updating it. And if we run out of data, we don't know what happened to him afterwards either. So we'll see what this causes later on. So because of this, new individuals enter healthy, even if they're sick, and take time to accumulate appropriate diagnosis. It may take up to 3 years for a person to get all of his diagnosis in line and have a good Medicare-based health history. Now it has poor data on demographics, no direct data on socioeconomics and behavioral habits, disease severity, cognitive and physical functioning, and especially in the early years, unless you're interested in white Americans and Black Americans, its ability to study other races not that good because it doesn't identify Latinos, Asians, and Pacific Islanders, etc. that well. It should be getting better as time goes on. But if you're especially interested in the early years, you're going to have a little bit of trouble. Now, these two graphs illustrate a problem, and that's the problem of diagnosis accumulation. We have two chronic diseases. We have Alzheimer's disease and we have chronic renal failure. Right? They're both chronic diseases. You don't get any better from these. And we just, for illustration, have two populations, the general population and people with diabetes mellitus. Now, as you see, it starts out fairly low because people are coming in 1991. We don't know what diagnoses they have. So the prevalence levels are artificially low in the beginning, and it takes a while for prevalence estimates to start being reasonable. Fine, so what's the problem? The problem is whenever we have a sizable influx of new people into the system. When did that happen? Well, it happened when Medicare Part D got introduced. As we mentioned earlier, Medicare Part D requires you to have Medicare Part A and B. You need to pay that premium. So around 2005, a large amount of people entered into the system because they wanted to get Part D next year. And they entered into the system as healthy people. Right? And they started taking time to accumulate their diagnosis. And this is why we have this little drop here, which later on recovered and went the same way as the rest of the trends. Now, this is visible in Alzheimer's disease. It's visible in certain other diseases. But look here, chronic renal failure. Can you see a problem? Not really. So if you didn't know to expect a problem, you wouldn't know that a problem is there. So being able to track potential new influx of people into the system is a fairly useful thing to do for any Medicare-based research. Now, many of these limitations can be addressed by linking Medicare data with other sources of information. Among them, we have Medicaid claims for low-income older adults who are eligible for both Medicare and Medicaid. We have surveillance epidemiology and end results cancer registry data. Lately, we can also link the National Death Index. Medicare does not provide a cause of death, although there are methods to impute it. But if you link in the National Death Index, you can get what's officially on the death certificate. There's numerous surveys targeting subsets of the Medicare population, like the Health and Retirement Study, the NLTCS, et cetera, lots of these. And most important for us in the study of Alzheimer's, the Outcome and Assessment Information Set and the Minimum Data Set. The first of these covers assessments for beneficiaries receiving home health care. The second of these for those in a skilled nursing facility. In addition, there's a lot of literature on measure validity, including validated disease ascertainment algorithms, reliability of race or ethnicity measures, how to deal with over/under coding. There's a lot of additional composite measures, usually indexes of various types, health-related indexes, ways to assign income and disability status, as I mentioned earlier, cause of death imputations. And there's a lot of new methodological approaches to get more out of the data, some of which have been discussed here. But the focus of this presentation is the minimum data set, right, which is highly useful, both as an additional resource for Medicare and for studying these people. The minimum data set contains the results of standardized comprehensive assessments of residents of long-term care facilities certified to participate in Medicare and Medicaid. The MPS was designed under contract to CMS, which was HICFA when it was designed, by a large team of experts and academic medical centers, and has undergone extensive revisions since the initial version, went from 1 to 2 to 3, and it is usually administered by a healthcare professional. May not be a great healthcare professional, but it's by a healthcare professional. So this isn't self-report, and this isn't per se an administrative claim, though it's an administrative record. And as we'll see later, it suffers from some of the same problems. The current version is 3.0, which contains 831 variables spanning several sections. Now, these are data variables, right? So on the instrument itself, they don't have 831 questions, right? A single question maps to multiple variables in the data set, and a lot of them are just administrative in nature. So it's not that you have one poor guy sitting in a nursing home and getting asked 831 questions. Right? It's much shorter and easier than that. In general, we have identification information, info on hearing, speech, and vision, cognitive patterns, mood, behavior, preferences for customary routines and activities, et cetera, et cetera, et cetera. A lot of the things in this list are quite useful to supplement Medicare analysis and to study Alzheimer's disease. The great news is that MDS assessments are implemented at the facility level, right? Not at the person level or at the bed level. If an LTC facility is Medicare, Medicaid certified, all residents receive the MDS assessment, independent of who's paying for the nursing home. MDS assessments occur on admission and annually, every quarter, on discharge, on occurrence of an adverse event, at a time of a major correction of something that was done previously, and there's several other specific cases depending on who's paying for your care. I'm just not going to list those, not that important. Not every element of the MDS is measured at every assessment. And the most detailed comprehensive assessments occur annually and on admission, which is not bad. Quarterly and discharge evaluations are non-comprehensive, but still designed to facilitate tracking the health status of the individual. The informativeness of the discharge evaluation improved between MDS 2.0 and MDS 3.0. So be careful if you're doing real longitudinal analysis of these things. Now, although Medicare does not cover long-term care itself, it will continue paying for the medical care necessary while the beneficiary was at the facility, thus still generating claim records in addition to the information provided by the MDS assessment. Now, Medicare will pay for short-term stays of up to 100 days, provided it is after discharge from a qualifying inpatient stay. There's more to the rule, but that's the short version. But again, since we're studying health, it doesn't matter who's paying for the person that brings you your coffee in the morning. It matters what diagnoses you're getting, right, what treatments you're getting, and what else is going on with your health. So as far as we're concerned, this doesn't bother us at all. The economists may disagree. They'll care a lot more. But, from health, not so much. So Medicaid pays for the majority of the LTC provided to older adults. Therefore, dual eligible LTC facility residents will also generate Medicaid claims. You can link all things and cross-reference. Now, the MDS is especially useful for the study of geographic disparities, as it is possible to study skilled nursing facility residents reasonably longitudinally at the facility level. Additional facility characteristics can be linked from the provider of services files, the nursing home compare. I think it's an information sheet, probably not even a database. And there are other sources which can also be linked. There are, again, two types of MDS data sets. Which one you get depends on the year. MDS 2.0, roughly 592 variables from 1999 to September 2010. MDS 3.0, 831 variables, October 2010 onwards. Again, this is just variables. So an element on the questionnaire that the nurse gets to administer can map into multiple variables in the data set. For the study of Alzheimer's, an important addition of MDS-3 is the brief interview for mental status, which is a direct measure of cognitive function. MDS 2.0 required the construction of a cognitive scale from existing variables, which actually worked. It wasn't a bad scale. It worked fairly well, but now we have one that's directly designed to test cognitive status. And there's articles on mapping BIMS into MMSE and some of the other mental tests which are commonly used. Unfortunately, the two versions are in no way comparable with each other and require extensive crosswalk. The RAND Corporation has a crosswalk available, but it is based on a pilot version of MDS 3.0. If you try to use it, it will not work at all. Right? So completely worthless other than as additional information. I was not able to find an up-to-date crosswalk using current versions of MDS 2.0 and 3.0. If anyone who is not me knows about such a crosswalk, send me an email and send me some effort in the future. Right? But using our own work, we were able to match 335 variables between 2.0 and 3.0. Unfortunately, many matches required additional harmonization, just like in the pilot. Only 110 variables translated directly without any additional intervention. Now, over the years, multiple instruments have been validated from the MDS. They've been found to have good validity and reliability. And in general, research thinks that MDS is an improvement over 2.0. 3.0 is an improvement over 2.0. Now, cognitive and ADL items were consistently the best performers. Notably, MDS-based cognitive performance scale was found to be strongly correlated with a diagnosis of Alzheimer's disease and other dementias, whether reported inside the MDS or from outside, like from Medicare, Medicaid, what have you. Unfortunately, depression, behavior, pain, and urinary tract problems were the least reliable. And for Alzheimer's disease, the low correlation between MDS depression measures and established depression scales poses a problem because depression is a big deal. It is questionable as to how much this has improved when we went from 2 to 3, as there have been reports that although the 3 depression and behavioral items improved in that they have high negative agreement, they still have fairly low positive agreement. So they're good at figuring out not depressed people, not so much at identifying depressed people. But MDS 3.0 discharge records have shown to accurately identify Medicare hospitalization events, and the reverse is also true. So 94 and 87% respectively. Similarly, high levels of correspondence were found between an MDS-based diagnosis and the use of appropriate drugs for the disease that was diagnosed. Now, like all data sets, the MDS is not without problems. Paperwork and reality often fail to coincide. There's evidence that long-term care facilities document higher levels of care than they actually provide, and underreport chronic conditions such as pain and depression. Again, this is a big limitation for Alzheimer's. Some even suggest that when using MDS, either use additional sources or quantify. This is probably for non-depressed people, which is probably a good thing to do. So there can be variation in the quality of assessments on the facility level. This is especially important if you're interested in racial disparities, because chances are disadvantaged groups are going to get into the ones that aren't going to be doing too well. There are probable incentives to both overcode, which gives you more money. Overcoding improves reimbursement, but also undercode, which helps you avoid audits. Audits are also bad. So the overcode, they have tendencies to overcode procedures that get you more money, but undercode procedures and health statuses that get you in trouble with the government who comes in and start checking your nursing home. However, many of these limitations are shared by many types of administrative data, and the extra information brought to the table by the MDS greatly complements and expands on the range of work that can be done with health records alone. So just to see how much of an overlap there is and how much we can track these different sources of data simultaneously, we took the health and retirement study, which is great in that the health and retirement study has these small components of pretty much everything you could ever want. A lot of the times the sample size are horrid, but not in this case. So we have Medicare claims, we have MDS 2.0, and we have MDS 3.0 evaluations. We're looking time in months from January 1999 to December 2015. We have a total of 8,000 HRS respondents that entered a skilled nursing facility for at least one day. And we're aggregating everything monthly. So these guys are spread out. And as you can see, eventually they die out. I didn't look exactly, but I suggest that there's a lot of people from the AHEAD database coming in early on, right? They combined in 1998. So in 1999, there's 80 plus people in here. And then they start dying off. So this is not strange. I expect to see something like this. Now, an average of stay lasted 100 days. And remember, 100 is the maximum that Medicare will pay for. The maximum length of a stay in an LTC facility was 3,079 days. So quite a lot of follow-up for at least one person. And 50% of all stays were greater than 78 days. So you'll get at least, well, the next line says it, right? You'll get at least 3 evaluations per person. For a single stay, the average number of MDS assessments given was 3.54, with a maximum of 51. Now, the green line shows us the number of people in a given month that has both evaluation, at least one, maybe more, and Medicare claims. The blue line represents people that didn't have an evaluation that particular month, but had Medicare claims. And the red line represents people that had in a given month only MDS evaluation. So the care is, as we can see, basically this huge green line, the care is happening simultaneously. You have Medicare records before admission. When you're admitted, you're still receiving care, right? And you're still generating claims. And when you leave or stay, you still generate claims. So with some care, we can track the same person, ideally, right? From becoming age 65 to getting sick to getting admitted once or multiple times into a long-term care facility. We suddenly get information on cognition, on disability, on a whole slew of other important variables. And we can continue tracking on a daily basis. Claims come out as you make them. They probably won't come out on a daily basis. They're bundled and file the paperwork once a week or something. But we can track these guys until death, pretty much. And if we can also link the MDI, we also know why they died. So this is an amazing resource to leverage, but it takes a lot of data sets because there's different sources of data which need to be properly linked together. People need to be identified which person goes to which episode of care. But again, other people have good luck with this 90% and up match rates. There are some useful resources.
We have about 3 minutes, 2 minutes left.
So we have the record layouts and the manuals, but more importantly, for anyone who wants to submit a grant suit, there's an online tool that allows a researcher to get an estimate of the sample size that can be expected from any recent year of MDS 3.0 data. This tool allows for sex, race, ethnicity, and state-specific counts. And this really simplifies filling out enrollment tables. And it's called the Minimal Dataset Frequency Report, and the CMS provides it free of charge and publicly available. And there are also some useful reading on the subject in general. Well, thank you. Any questions? I'll be glad to answer.
Thank you.